Yeah. Yes, go ahead. So if you don't mind everybody to have a seat, so we'll start the third session and last session for the morning. After that, there will be a lunch program in the fountain hall. When you exit the room, you go to the left side, and the fountain hall is in the left side there. Please join us at immediately after this for lunch session. So it's my pleasure now to introduce our moderators for the third session. Dr. Cody and Dr. Flora, you can go ahead and lead the session. Thank you.
Thanks for having me, Dr. Jazzy, my oldest and wisest mentor when I was a new baby fellow. It's good to have him back, isn't it, everybody? Pulling us all together. I have the privilege of introducing our next guest, our next speaker for most of our breast center moderations today. I think probably we know his name well. He's a nationally renowned breast cancer expert for decades here. Dr. Pushtai comes from Yale, where he directs most of their breast cancer therapeutics and a lot of their programming involving genetics, genomics, epigenetics through the Yale Cancer Center. He's the chair of the Breast Cancer Research Committee of the Southwest Oncology Group, and we've been watching his involvement in our lives as breast cancer doctors for decades and helping us target our therapies more intelligently. So I thank you for that, and my patients do as well. So if you will, warm welcome.
It's really a great pleasure to be part of a face-to-face meeting again after about 2 years. So I congratulate the organizing committee for actually putting this meeting together for all of us. So I'm going to review with you what happened in the past 12 months in breast cancer, because I think there were some really paradigm shifting results that came out. Now I try to move my slide. Oh, okay. Yep.
And then because of the virtual audience, you just go into the slide, not
Thank you. So these are my disclosure slides. For sake of time, I just have to move on and not read this out for you. So there are two really important events happened in early stage breast cancer in the past sort of 2 years. These are the PARP inhibitors came to age in breast cancer. And I'll show you the results of the Olympia trial and put this into context with some other studies that were reported at ASCO, like the NEO-TALA study and the CREATE-X and the ECOG 1131 trial that helped to guide adjuvant therapy for patients with triple negative disease who had residual cancer after new adjuvant chemotherapy. The other important advance really that immunotherapy has come of age in breast cancer, both in the early stage and metastatic setting. So this is the Olympia trial design. So you can see this was an adjuvant trial for women who had germline BRCA mutations. The eligibility criteria restricted participation to women who were high risk for recurrence. So this included triple negative germline BRCA patients who either had a 2 centimeter tumor or larger, or had any tumor size but positive nodes, or if they received neoadjuvant therapy, then they had residual disease. For the ER positive group, the eligibility criteria was even stricter. If you started with surgery first, then you had to have 4 positive nodes. So this really strict eligibility criteria, thanks for God, we don't see that many ER positive patients with 4 positive nodes, really will reflect on the final accrual composition of the trial. So if they received neoadjuvant therapy, they also had to have residual disease, just like in the triple negative patients, and had to meet a criteria by what they call, by a scoring system, a CPS, which is basically the extent of the residual cancer, grade, and the ER, extent of the ER staining in the residual tissue. So they were randomized to placebo or 1 year of olaparib. So this is the actual patient distribution in the trial. So what I wanted to point out to you that about 80% of the patients were triple negative. And again, that's because of the eligibility for enriching the study population in high risk women. And because of that, the germline BRCA mutation was mostly BRCA1, which is the mutation that's associated with mostly with ER negative tumors. So it's a fairly young age group, about 40, early 40s in terms of their median age. And they received pretty appropriate third-generation chemotherapies if they received adjuvant chemo or neoadjuvant chemo. Then most of them did. So this is the result. So both the invasive disease-free survival and most importantly, the distant metastatic-free survival and also overall survival improved with olaparib. So with a median follow-up was around 3 years. The actual 3-year invasive disease-free survival was 77 versus 80. I can read this from here, but it's about a 9% improvement in recurrence-free survival. And most of the events that were avoided were actually distant metastasis. And that's very important because this really bodes well for improving cure rates for this woman. And indeed, you already see an improvement in overall survival, which have not met the statistical sort of requirements set by the study, even though the p-value is less than 0.05. In fact, it's 0.02, but it has to be 0.01 because of the multiple looks to declare the overall survival significant. And there will be subsequent follow-up to this study to look at the survival. So based on this, the ASCO and the NCCN already updated their guidelines. So the new standard of care in the adjuvant setting for a germline BRCA positive woman, ER positive or ER negative, is olaparib, although this is not approved by the FDA yet. So what's the price that the woman paid for this in terms of side effects? So GI and hematological side effects were more common. So the most common grade 3 adverse event, as you would expect, was anemia from olaparib. And there were also neutropenia and leukopenia, although less frequently at the grade 3 level. And by and large, this drug can cause nausea and vomiting. And you also see this in the this toxicity result. So most of these patients were actually triple negative, and most of them received neoadjuvant chemotherapy. So you must be aware that for patients with neoadjuvant chemotherapy with residual disease, triple negative setting, they benefit from adjuvant treatment with regards of capecitabine. And that's the CREATE-X study, which was published about 3 years ago or 4 years ago now in the middle, that shows you that adjuvant capecitabine improves disease-free survival or recurrence-free survival. At ASCO, there was another study that was reported which compared in the same population, triple negative residual disease after neoadjuvant chemo, capecitabine versus a platinum agent. The idea behind this study was that triple negative disease might be more sensitive to a platinum agent rather than capecitabine, and the platinum will be better. That didn't pan out. So there was no subgroup within this population where actually platinum would have beaten capecitabine. They were equal, but the platinum-based arm had more toxicity. So the standard of care remains the capecitabine. But this also poses the question, so which drug will you use, capecitabine or olaparib? Unfortunately, the FDA did not allow modification to the study to allow combined use or concurrent use of capecitabine or olaparib in the Olympia study. So there's no really clinical trial that guides the selection here. So I'm going to share with you my opinion that which might be the better drug in that setting. So remember, in the first line and second line metastatic setting, there was head-to-head comparison of olaparib in germline BRCA mutant patients with physician's choice chemotherapy. And about half of the time, the physician's choice chemotherapy, around 40% of the time, was actually capecitabine. So there are 2 randomized studies in this space, one comparing olaparib with physician's choice, the other one talazoparib. And both of these studies actually showed that the PARP inhibitor was better than physician's choice, including the capecitabine drug. So based on these results, one could argue that probably the better choice to treat micrometastatic disease is the olaparib rather than the capecitabine. And the combination is completely unproven in terms of, or untested in terms of toxicities. So obviously, we would expect substantial added toxicity in the combination. So I wouldn't suggest that you do that. So just again, to really show how remarkably effective the PARP inhibitors are in germline mutant cancers is this neoadjuvant talazoparib study that was a follow-up to a smaller phase 2 trial from a single institution, my former institution, MD Anderson, which reported that around 40%, 50% pathological complete response rate to single agent talazoparib. So this is a follow-up with a much larger population. And again, this is it's a really bold study. So these are triple negative patients with germline BRCA mutation receiving single agent talazoparib preoperatively for 24 weeks. And look what actually they found. So this is just the patient population. Again, so these are stage 1, 2 triple negative patients with germline BRCA mutation and mostly BRCA1. So this is the pathological CR rate by the investigators' assessment and also by a central review committee and for the entire population and for an evaluable population. Or intended population, the evaluable population. And in each of these breakdowns, the PCR rate is around 50%. So just to remind you, this is about the PCR rate that carboplatin plus Taxol plus dose dense AC produces in that setting. Yeah, so what I wanted to point out that, so this study was a triple negative study, but the previous phase 2 trial that really prompted this larger study included ER positive patients as well. I just want to point out to you that in that study, there were 5 patients with ER positive cancer and 3 of them had a complete pathological response. You know that in ER positive cancer, regardless of what chemotherapy regimen we use, pathological CR rates are pretty rare, even if you select the most chemotherapy sensitive subset, the luminal Bs with high proliferation, PCR rates never amounted to more than 20% in ER positive cancers. So with talazoparib, this actually looks potentially a much higher PCR rate. So I'd like to move on to the other major, I think, breakthrough in early stage disease, and that's the role of the immunotherapy drugs in triple negative disease. So the Gepar Novo was presented at ASCO, but the Keynote 522 survival or progression-free survival results were presented at the ESMO meeting, and they both show improvement in recurrence-free survival with the inclusion of immunotherapy. So this is the Gepar Novo study. That was a neoadjuvant trial for triple negative breast cancer, regardless of PD-ligand-1 expression. They were randomized to nab-paclitaxel for 12 weeks, followed by AC, epirubicin, cyclophosphamide, with or without durvalumab throughout the chemotherapy. So please remember, there was no durvalumab after completion of the surgery, unlike the other neoadjuvant trials, which always continued for 1 year, the immunotherapy component. So Gepar Novo didn't do that. It's a pure neoadjuvant trial. The pathological CR difference was about 9% or 8% in this small study of about 174 patients. This did not reach statistical significance. But I'd like to point out to you there in this little insert that what we really mean by being underpowered. So if you keep the exact same proportions, the 44.2% objective pathologic CR versus 53.4%, if you actually have the same proportions in a 500-patient neoadjuvant trial, this would be significant, statistically significant. However, in the small study, it wasn't. And just to point out to you in this last panel there, that patients with high immune cell infiltration, high PD-ligand-1 expression, or high gene expressions for immune cells, they all have a higher PCR rate, but they also have a higher PCR rate with the immunotherapy drug, regardless of what these markers are. So none of these markers could be used to select patients in the neoadjuvant setting to identify the group that needed the immunotherapy drug, because regardless whether these markers are low or high, both groups had an improvement in PCR rates, but the very highest PCR rates are in these immune-rich cancers that had the chemo plus the immunotherapy. So this is the result which was presented at ASCO. The distant disease-free survival and overall survival were actually remarkably better in the group that received the durvalumab upfront, despite the relatively modest increase in the PCR rate. I think this is partly due to the effect that there is a massive downstaging. So remember, actually, I was really delighted to hear how pathologic CR took on in other diseases, because we actually introduced the concept as an early surrogate of efficacy about 18 years ago or 20 years ago in breast cancer. You may not remember this, but at that time, the way people measured response to neoadjuvant therapy was mammographic imaging, or the NSABP had a definition of no cancer in the breast, but they disregarded the lymph nodes. And of course, if you have positive nodes, even if you have no cancer in the breast, your prognosis is really bad. So we're really delighted to see that PCR is actually having a renaissance. So anyway, the main point here is that there is very little residual disease in these patients. So even though we call them residual disease, they actually have minimal residual disease. And that's probably contributes to this remarkable improvement in their disease-free survival, even without continuing the immunotherapy. So that's, yeah. So what I want to point out on this slide is that this improvement was seen in the group that had residual disease. So those who actually had residual disease and didn't accomplish pathological complete response, the group that had the durvalumab actually did better. So how does this stack up with the larger studies like Keynote 522 and the Impassion 031 that tested pembrolizumab and atezolizumab respectively? These studies showed the exact same thing, a relatively modest improvement in pathologic CR rates. In the Keynote 522, this eventually ended up to be a delta of 7%. And again, as I pointed out to you earlier, you see this improvement in the PCR rate in both groups, the PD-L1 positive and negative groups. And this is the updated survival result from the Keynote 522 at ESMO. And again, you see this, that the pembrolizumab group did significantly better in terms of event-free survivals. And also again, to point this out for you on the other part of this slide, that the no PCR group, the residual disease group with the pembro, again, did better. I think it's primarily because the massive downshift that you see in the residual disease categories. Obviously, it's not one group. You can have a residual disease that's 0.5 centimeter versus 3 centimeter. So in the pembro arm, the diseases are mostly in the 0.5 centimeter range. We're going to show these results in probably at a future meeting, maybe at San Antonio. So based on this, this is now approved by the FDA as a neoadjuvant treatment. So the side effects are the expected side effects. Unfortunately, about 20% of the patients, at 25, will get some immune-related side effects. And these are mostly asymptomatic thyroid dysfunctions that you pick up with TSH levels. But of course, there are some more severe and symptomatic issues such as colitis, hepatitis, and neurological complications. Just to summarize this early stage advances here. So I think that results from the Olympia trial has changed practice. So for germline BRCA mutant early stage breast cancer, olaparib is the standard of care as adjuvant therapy. And it's probably the better choice than capecitabine for triple negative patients. For ER positive patients, you of course give concurrent endocrine therapy as it was given in the Olympia trial. And these results are really supported by a whole lot of other studies that establish the value of single agent olaparib in metastatic disease and even in the neoadjuvant space. And the Keynote 522 again has changed practice. I think for most of your high-risk patients, that stage 2, stage 3 triple negative breast cancer, the appropriate way to treat them is neoadjuvant therapy with inclusion of pembrolizumab, because that maximizes their chance of cure. And if they have residual disease, they could get the capecitabine. That maybe I move on to the metastatic studies. So the metastatic studies were a little less exciting in terms of immediate practice change, but they included many studies that really confirm that what we are doing is the right thing to do, particularly in the CDK4/6 inhibitor space. And I'll point out to you one study that I thought was really interesting and potentially chart the future for metastatic disease and immunotherapy. So I'm going to show you the Paloma 3 and the Mona Lisa 3 overall survival results, and an interesting study with the immunotherapy combination. So this is the Paloma 3 trial design. So remember, this was a metastatic study for first or second line treatment for patients who progressed on a prior endocrine treatment either recurred during endocrine adjuvant therapy or progressed on their first line endocrine treatment. And they could have received one prior line of chemotherapy. And that's going to be actually interesting to look at how different the outcome was based on who got chemo first or who got the endocrine therapy before the chemo first. So they were randomized to Fostrox with or without palbociclib. And this is the updated survival result, and shows that there's at about 6 years of follow-up, the overall survival is significantly better with palbociclib. And this was seen regardless of the biomarkers that people sort of associate with ER-positive disease and poorer outcome, like ESR mutations. Palbo helped regardless whether you were ESR mutant or not, or PI3 kinase mutation. Again, palbociclib worked quite well and improved the outcome in the PI3 kinase mutant group, and also for TP53 mutation. This next slide is actually going to be interesting. So look at the overall survival in two more or less equal size groups, those who got chemotherapy first and those who actually got no chemotherapy for their metastatic disease. They started out with endocrine treatment. And you see the difference that in the no prior chemotherapy for advanced breast cancer group, the overall survival is really significant, but there's no survival benefit in the group that had chemotherapy first. So why would you give chemotherapy first for an endocrine patient? So this is a little more of a breakdown, right? So you probably would do that because there is a sort of a widely held, but not based on any study assumption, that people who have visceral disease need chemotherapy. I actually wondered about this, where this came from. It's never been shown in any study. It actually dates back to the 1980s, where I think Craig Henderson or some of the earlier generations of giants noticed a simple thing, that tamoxifen takes a longer time to act in the metastatic setting than chemotherapy does. So that's the idea behind this thing, that if you have a visceral disease, you give chemotherapy because the assumption that chemotherapy might work faster. This may hold up for tamoxifen, but it's really not holding up for the modern therapies that we actually have. And this is the breakdown that shows you this. So those who actually had no prior chemotherapy and had visceral disease did just as well as the folks who actually had no visceral disease. But if they got chemotherapy before, then they didn't do so well, regardless whether they had visceral disease or not. So I think this really puts this idea to rest, that you should start chemotherapy in ER-positive patients 99% of the time. You should start with endocrine therapy and the CDK4/6 inhibitor. So the Mona Lisa 3 trial was very similar, with one exception, that it really did not allow any prior chemotherapy. But patients could have had 1 or 0 prior lines of endocrine therapy, and they were randomized the same way, fulvestrant with or without ribociclib. And the overall survival results are shown here again. There is an improvement in overall survival. This improvement is more pronounced in the first line setting as opposed to the second line setting. And again, the message from this is that if you want to get the best mileage out, then it's best to use this in the first line setting rather than the second line endocrine setting. It's best to use them before chemotherapy rather than after chemotherapy. And again, I just pointed out in this little insert there that there you also see that if they had visceral disease or not visceral disease, that the red arrow shows you that the benefit from ribociclib was the same. So yeah, so ribociclib really had a remarkable sort of run in the past few years, because all the 3 of their studies, the Mona Lisa 2 with no prior chemotherapy and first-line endocrine treatment, showed the overall improvement in survival. The Mona Lisa 3 that I just showed you, improvement in overall survival. In the Mona Lisa 7 for younger women, and there they allowed 1 prior chemotherapy, but no prior endocrine therapy, again, showed overall improvement in survival. So there is very little doubt that ribociclib and also the other CDK4/6 inhibitors can improve overall survival. The earlier you use them, the better mileage you get. So this is the study that I showed. I just sort of bring to your attention from the large number of really interesting phase 2 studies that are always shown at ASCO. So this was a study from China. It's first-line metastatic triple-negative breast cancer, which enriched for CD8 positivity. So they are enriched for immune cell presence in the cancer. So remember, this is the current indication for pembrolizumab. Right? The first-line triple-negative breast cancer with PD-Ligand 1 expression, CPS greater than 10, which matches very closely with high immune infiltration. So they took that population and they tested their own PD-1 drug that is called pembrolizumab, together with nab-paclitaxel, and together with famitinib, which is a VEGFR, PDGFR c-KIT tyrosine kinase inhibitor. It's a 46-patient study. They reported this astonishing 85% objective response rate and about a 55% or 53% 10 months progression-free survival. So I've never seen response rates like this in triple-negative metastatic breast cancer. So remember, chemotherapy does about a 30% response rate. And what chemotherapy plus atezolizumab or pembrolizumab does, you will see on the next slide. Actually, the next after this one. So that's the toxicity. This really had the toxicities that you would expect from a VEGF inhibitor and an immunotherapy drug and the chemotherapy. So this is the two large studies. The Keynote 355 is landed pembrolizumab, the FDA approval as first-line therapy with either gemcitabine, carboplatin, or Taxol or nab-paclitaxel. And the Impression 130, which showed the exact same thing, but it was eventually withdrawn from the market by Genentech. But I want to point out to you the response rates in these groups. So chemotherapy alone is like 46% response rates. When you add on the immune checkpoint inhibitors, pembrolizumab, it goes up to 41%. And with the atezolizumab at about 56%. And even in the immune-enriched populations, these numbers don't really change. They don't come nowhere close to 80%. So it is possible that this may be the future to really push immunotherapy efficacy in triple-negative disease. So just to conclude this again, so palbociclib improves overall response, overall survival, added to fulvestrant in the first-line or second-line endocrine therapy setting. Ribociclib also does the same. And this phase 2 study is quite fascinating in the sense that it showed a remarkably high objective response rate and a pretty decent progression-free survival when sort of an anti-VEGF tyrosine kinase was added to the immunotherapy plus chemotherapy regimen. So these are my slides. And if you have any questions, I'm happy to answer. Yeah, I can actually also repeat it. So you said that when carboplatin was added.
So my question was on neoadjuvant trial that led to pembrolizumab approval in neoadjuvant settings, right? They use carboplatin with taxanes, right? So the question is, how much is that important? And considering a number of studies had controversial results previously, and considering that we're trying to kind of diminish role of chemotherapy, emphasizing the immunotherapy component. What are your thoughts on that?
I think it's not that important to include a carboplatin. So that's the FDA-approved regimen, but it adds toxicity. It's also clear that this is probably the regimen that induces the highest response rates. But remember, so the Impression, the other neoadjuvant trial with atezolizumab didn't have the carboplatin component, and the I-SPY2 study, which actually motivated the pembrolizumab trial, only used the pembrolizumab only with a Taxol component. And it was not even continued with the AC part and showed a remarkable improvement in PCR rates, right? The Gepar Novo that I showed you didn't include any carboplatin either, and it showed a remarkable improvement in the event-free survival, which really drives the approval. So remember that the FDA initially tabled the approval, and a month later, actually, 2 months later, they approved it when the event-free survival become clear in the Keynote 522 study. So I think if you want to be really aggressive, then you include carboplatin, but I don't think that that's really necessary to see the benefit that you see. And that's because the same benefit is shown in the Gepar Novo. The atezolizumab trial didn't include that, and also the I-SPY trial in the neoadjuvant setting didn't really include carboplatin yet, showed the benefit.
Other questions?
I'm going to ask you to put on your other hat. It's on. It's working. Your other hat is the co-leader of your genetics program. You mentioned how this is changing the standard of care in our approach to adjuvant based upon the Olympia study. Has it changed your general approach to more universal germline testing in the patients for whom that might be of benefit?
Yeah, so I think that's a very important question, that how do we handle this now in the sort of traditional setting of how we test germline testing? Yeah, I think we should really test everybody for germline. But the reason for that is because we miss. So the current NCCN guidelines, I can guarantee that you all remember the triple negative recommendation, right? Every triple negative breast cancer patient, 60 or younger, should get BRCA testing. That's good. But the ER positive, nobody can remember. I certainly can't. And I think that even my geneticist colleagues can't, because it's a very complicated Byzantine setting. I think where the field is moving is that probably there will be a uniform recommendation that all breast cancer patients 60 or younger should get BRCA testing, because they can miss out on a potentially life-saving treatment. So how often do we miss out? Well, 3 or 5% of the time we do miss out. So women in their 60s or in their late 50s who don't meet any of the criteria, still BRCA positive. It's been very well documented in large studies now that really the NCCN guidelines enrich for BRCA positive patients, but they by no means capture all of them. And leaving some out who are BRCA positive is potentially because their life, right? Because of this. But I think we will need to somehow adjust our current system, because it probably wouldn't be able to handle every single breast cancer patients for BRCA testing through the conventional sort of mechanisms, or they will need to be scaled up. And the conventional mechanisms is that we order these tests through the genetic screening clinics, which tend to be pretty small compared to the volume of breast cancers that would need to be tested now in the context of the, or after the results of the Olympia.
I just had a practical question for patients with triple negative breast cancer, say a multiple node positive, triple negative, treated on the Keynote protocol, partial remission. Is there a role then for adding the capecitabine? You would still.
So I would do the capecitabine. So unlike the olaparib plus capecitabine, where there is really no data that how safe that combination is. There is safety data in phase 2 studies with capecitabine and pembrolizumab. In fact, there is a huge amount of experience with pembrolizumab combined with any chemotherapy that you know of. And we know that this is a pretty safe combination. There is no synergy between the chemotherapy-related side effects. The pembro only brings in its own additional side effects, the immune-related problems. So I would do both, even though, again, the FDA unfortunately rejected the amendment to include or to amend the protocol to allow concurrent use of capecitabine and pembrolizumab. So we don't have data. But I think in the triple negative setting, the combination is pretty safe. We know this from prior experience. And I think it's better, probably better than the one alone. But
Other questions? Difference, BRCA1, BRCA2 treatments?
Yeah, I didn't point this out in the slides, but there was no difference in terms of efficacy in the Olympia based on the BRCA1 or BRCA2 results. It's actually in the manuscript in these forest plots that I also showed, but I didn't point this out.
Hi, I just wanted to comment, since I might be the only genetic counselor here. And I just wanted to say, like, there has been some frustration with genetic counselors in that, we've been bottlenecked and you can't get into one very quickly to get the germline testing. But I just want to say, like at TriHealth, we have a universal breast testing protocol. We have the blood drawn at the surgical visit or the med-onc visit. And we do the consenting digitally, and we call out, the genetic counselors call out the negatives, and then we manage the positives for cascade. And similarly with ovarian cancer, we're doing the paired tumor germline, where the ovarian, the genetic counselors are actually ordering both the germline and the tumor testing even before surgery is done. So I think, you just have to be creative and innovative the way you use your genetic counselors.
That's right. So I think you're absolutely right. So I think the ideal solution would be to really scale up the scope of the genetic counseling services in places where that's a bottleneck. Because of course, the complexities of counseling somebody about the germline BRCA mutation doesn't go away just because we have a positive adjuvant study that could improve their survival. The issues, there are many additional issues to consider. And explaining that is probably best done in the context of genetic counseling. I agree with you. That's great. So thank you.
Thanks very much.
Thanks very much.
Well, I would like to thank you, Dr. Cody and Dr. Flora, for moderating the session. And now for the virtual audience, I wish we reached the level of having virtual lunch for you guys, but you may have to eat on your own. For those who are our guests here, the lunch will be served on the Fountain Square when you get out of the door to the left side. So we have lunch program there. Please, go ahead and proceed there. The lunch will be served at 12. Thank you very much. We'll be back sharp at 1, please, at 1 p.m. Thank you, in 1 hour. Thank you very much.